Right. Chairman, ladies and gentlemen, I would like to thank Ziad and Damien, as well as the organizing committee, for inviting me to participate in this PICS meeting, and the program looks absolutely excellent. I'm talking about the use of CTO wires, which has been mentioned by Dr. Ayasian a little bit earlier. And these are wires which have been developed initially for vascular work, but more recently and in a very advanced way for coronary artery work. Increasingly, we are seeing problems with vascular problems. That is because we're doing more intervention, we're using bigger devices, we have patients who have more frequent surgery, staying on intensive care unit for a long time, and therefore we're using very vital vessels, both on the venous as well as the arterial side. But in addition to that, we do deal in congenital heart disease with obstructive lesions, and therefore, if there is any device which is going to help us overcome that, that would be extremely helpful. Obviously, we already have some devices which we can use to overcome obstruction, and these could be simply mechanical ones. We also have radio frequency, and potentially there is also laser. In the past, we used to make do with anything that we had to try and do an intervention, but increasingly we're getting more sophisticated and special devices which help us to get a better result, a more safe result. And I think it's important to try and embrace new technology, because if you have a good tool, you're more likely to get a good result. So to be a master, you really need to not just have the skills, but also to have the good tools. So in terms of the systems that we will require, it's not just the wires that have been designed for chronic total occlusions. We need to make sure that we do deliver them with the right kind of technology. These wires do not work on their own. They do need to have the pushability against the lesion so that you can actually cross it and then be able to open it up. And to do that, you do need to have support. And most of the time, a guide catheter, which is relatively strong, but it's not just the strength of it. You do also need to have counterbalance. In other words, if you have a catheter which is just floating in the aorta, for instance, you just do not have the pushability to use these wires. The reasons why they work, for instance, in coronary artery disease is because the guide catheters are designed specifically to anchor them and for there to be counter pressure when the wires are being pushed forward. So we do have some limitations in congenital heart disease because the anatomy is a little bit different. But wherever possible, do use either a very strong sheath or a guide catheter. There are different types of CTO wires, chronic total occlusion wires, and these have very, very different features. They are not all the same. The way you handle them is very different. Their pushability is very, very different, and the risks with them are very, very different. So before you use them, and you don't need to know the details of all of them, but the ones at least that you use, and you probably don't need to know more than about 3 or 4 of them, then it's important to know the features so that you know how to use them, not just for success, but also to reduce the complications. In addition to these wires, there are also other devices, and one of them I'll show you is a device called the Tornus. In addition to the wires, the use of microcatheters, similar to the ones that have already been described for neurosurgery, for neuroradiology, are very, very helpful. These are braided. They range from about 2.1 to 2.8 French, so they can go through a guide catheter, but they give you the support and the additional pushability to be able to get these wires across an occluded lesion. Now, sometimes these wires are not long enough, and it's important to appreciate that if you do need to have an additional length, you can use a dock system. So you dock one wire to another to get the length. But there are some wires which are very long, such as the Asahi RG3, which is about 330 centimeters long. So it is important to know what kind of lesion, what kind of length you require, and either have an extender or use a very, very long wire. Once you've crossed these lesions, it's important to do a dilatation, and obviously it's not always possible when a lesion is completely occluded to cross with a balloon, but there are some balloons which are extremely low profile. In other words, they have no profile at all. So these are very, very, very fine, There's no wings to them, and you can actually push them over a wire and start inflating, creating a track, and then increasing the size of the track by increasing the balloon diameter. And two examples are the Sprinter and the Stingray. One of the companies that does make, and I have no link or any association with the company, but they do have a very large array of chronic total occlusion wires, is Asahi, which is a Japanese company. And I think it's important to appreciate that the wires have different tip load. And the more tip load you have, the more successful you're going to be, but the more likely that you are going to be able to perforate. And they all work in a different way. So the more gentle ones are the fielder catheters, or the fielder wires, and there are two types, one which are used for antegrade and ones which are used for retrograde. These only have a tip load of 0.8 grams. Then there's an array of Miracle Brothers, and depending on the stiffness of the tip, you have a variable tip load. So it can be 3 grams, 12 grams, or somewhere in between. One of the ones that has been, we've used a lot is the Ultimate Brother, again made by Asahi. It's only 3 grams, but it is generally a very, very good wire because the tip of it is quite soft. So it's very good for certain lesions which have a bit of an angulation or a bit of a curve. So I think that is one of the wires that one should consider using. Although the wires come as straight, you can always put a little bend on them, but it's very, very important not to put too much of a bend because obviously if you have something which is bent and you try to rotate it, that is going to change the orientation of your bend. But when you do have a bend, or when you create a bend, it's very important not to just rotate it, but to actually move it back and forth so that you keep it in the same direction. More stiff wires, again, these are largely for coronary, but also for peripheral work, is the Confianza and the Conquest Pro. The really heavy ones, and this was mentioned again by Dr. Asian, is the Astato. These are really very, very stiff wires, and the risk of perforation can be quite high. So it is very, very important to make sure that where the wire is going in the right direction. They're only 0.014 in dimension, most of them. Some are 0.018. So it's not a very big perforation, but nevertheless, you can still get bleeding. The microcatheters that I've mentioned, which are braided catheters, come in various forms. They're usually just over 2 French, so from 2.1 to 2.8. And there are different types. These are the ones that are commonly used. The ones that I tend to use more are the fine cross and the prograde, and these are catheters. Again, they can be quite long, so you may need to use a dock system to increase the length of your wire. I mentioned that there are additional devices, and this is the Tornus. And this is, it's got, as you can see at the tip, a little screw-type design, so you actually burrow your way through with this device. Now, we're all grown up here. You know, we screw clockwise, and that is an engineering technique. But with this one, you screw anti-clockwise. It's a Japanese design, and you screw it anti-clockwise. But it is a very, very good tool. If you can't create a perforation, particularly in a vessel, using this device is really very, very, very helpful. Now, it's important to know the details of the lesion because you otherwise will not know how you're going to get a good result. So some of the lesions have a blunt end, some are tapered, so you have to have good angiography. You need to know the length of the lesion. If you can't see it at the time of angiography, CT scanning may be helpful. The course and the angle is also very important. If these are very, very acute, the wires are not going to be very helpful unless you can get a good purchase on the vessel. The size of the distal vessel beyond the obstruction is very important because you need to know how big a balloon you're going to use or a stent, and obviously to see whether there's any collateral supply because sometimes you can approach them retrogradely. As far as the wires the details of the wires are concerned, you know, why have they got the ability to go through perforations? The reason is because of the design. Some of them have a design which is partly soft at the tip, but also has the pushability, and this is by the coil mechanism that they actually put through. The more coil there is, the stronger the wire. But it's also the covering, the polymer cover. It's like a hydrophilic type of material, so it makes the wire actually go through these occluded vessels or lesions. Most of you will know that even if you use something like an 018 straight terumo wire, you can go through many occluded lesions, and this is the principle of having them covered with polymer. As you can see, this is one of the extenders or the dock systems to increase the size of your wire. The chronic total occlusion wires, these are the more stiff types of wires which most have to use for the types of lesions that we have. So it is important to look at the anatomy to see what kind of problem you're going to have, where the proximal and the distal end of the lesion is, what the orientation is, and whether you're going to be able to meet the two ends together. But I think it's also important then to appreciate the properties of the individual wires. So sometimes you need to do a drilling type of mechanism, in other words, going back and forth, like rotating back and forth. Sometimes you have to do it in a sliding technique, so you rotate it in a clockwise fashion, but going all the way through and pushing at the same time. But for the more stiff wires, you then use the penetrating technique. In other words, you actually tap it. You tap the wire as you go forwards. So it's important to appreciate which wires benefit most from which of these three types of techniques, which is the sliding, the controlled drilling, or the penetrating technique. So apart from occluded vessels, what other potential lesions can we deal with? Obviously, the pulmonary atresia is a very classical one. Sometimes you can open this up with the stiff end of a coronary wire. Most people use radiofrequency, but obviously radiofrequency needs to have the equipment, but also there is the burning component to it. So using these wires certainly doesn't cause any burning. You already have a wire that you can take a coronary balloon catheter over, and therefore it makes it a lot easier. Occluded veins and arteries, these are by far the most that we encounter. In our unit, we have a very big liver transplant unit. So they do a lot of liver transplants, small bowel transplants, and these patients have been on long lines for many years, and therefore they finish up with occlusions, and we have to rehabilitate these for them prior to transplantation. Recanalizing the duct is very, very important. Many a time we find that there are congenital heart lesions with reduced blood flow to the lungs where the duct has actually closed. In this situation, opening it up, so long as there's an ampulla, is not a problem. And we've opened some that have been closed for several years. You can open up occluded shunts and also crossing an intact atrial septum. So these are some examples. This is a patient with phallocetrology from Nepal who had several operations in Delhi. We had no operation details, but when she arrived to us, she had a systemic RV pressure. We realized that there was a tight RPA stenosis, so we stented that, but the LPA was not filling at all. So as you can see, there is a ductal ampulla at this point here. Doing a wedge injection, you can see a very, very small left pulmonary artery, a true wedge with a bronchogram. You can see again a very, very small left pulmonary artery. We had a guide catheter. We used an ultimate brother here. We can see that it's taken the course of the vessel. Once you actually reach once the tip of the wire reaches the hilum, you can actually see it moving, and you know in that situation that you've actually got to the lumen of the other end. Once you've got the wire in, you can put one of these very, very low profile balloons here, and you can track it all the way, starting from distal proximally. And once you've done that, you can start stenting distally, more proximally, until you stent it completely. This is a completely stented vessel, and you can see much, much better flow. These were 3.5 millimeter stents, and 6 months later, we dilated them to 6. So it's important not to open from 0 to something very big because of the risk of rupture. This is a patient who had complex congenital heart disease and was very dependent on 2 shunts. She had an attempt to stent this in another place, and in fact, they actually dissected it and occluded the shunt completely, so she became extremely cyanosed. This is an adult patient with saturation in the 50s. So again, we used a combination of wires in this case. Mostly we used the Confianza, but we also used the Taunus, And once we went from there to there, you can see that we were able to establish very good flow to the left pulmonary artery, and eventually we stented that. This is a venous occlusion in a patient with a Fontan. You can see that the IVC fills up to this point, then it goes to this very, very tortuous vessel, which eventually finishes up in the hemiazygos vein. There's occlusion at the level of the hepatics, which is at the point here. So we have an 11 centimeter occlusion here in the IVC. This patient was quite symptomatic with lower limb circulation. And again, you can see this is very similar to that. So there's no flow from here directly to the heart. So we managed to cross from the top with a chronic total occlusion wire, snared it at the bottom, used an Atlas balloon to dilate the track, and then eventually we put two telescoped, purpose-built, customized covered stents from Cook, and we were able to establish continuity between the IVC, and you can see here the IVC and the right atrium, just at the level of the caudate lobe of the liver. So it's a bit nerve-wracking because you're creating a big hole between vessels with no real protection, but it seemed to work well without any obstruction. You can use it for other things, like this patient with a mustard operation with an occluded SVC. Once you've crossed, you can actually put a stent. And we also can rehabilitate vessels in patients. As a patient with transposition who had pulmonary artery stenosis, and we needed access for intervention, and you can see we put a series of stents, having crossed it with a CTO wire. Another patient, this is an arterial problem. This is a patient with coarctation who had occlusion of both femoral arteries. And you can see that there's a reasonable femoral artery, but here the iliac is occluded. So again, we went with an ultimate wire, ultimate brother wire. We used one of the low-profile balloons, and then we eventually worked on this to create a track. We did not actually stent this one. We actually did serial ballooning, but we felt that as the patient was quite young, we should simply just balloon it to make sure that the lower limbs get good circulation and growth. Again, use in pulmonary atresia with intact septum, and then once you've got the wire through, you can put a balloon catheter, coronary balloon, a bigger wire, and then you can actually open up. This is a patient who's had several operations, again, for pulmonary atresia. She's had several shunts, and as you can see that there is a stump at the top from a shunt here, and through a wedge you can see a very, very nice left pulmonary artery, and I thought this would be very, very easy to go from A to B. Unfortunately, I failed on this occasion, and I think one of the reasons is that the orientation of the stump to the left pulmonary artery is such that you do not have the purchase to go from there to there. So do use biplanes, and sometimes it's going to be impossible, or you're going to have to fail, and you have to accept that. So in conclusion, we do have these new wires which have been designed for vessel occlusions, but we can also use them for coronary artery, so for congenital heart disease, as I've mentioned, with some of the occluded lesions. And I think particularly patients who've had a PDA which has closed down, and you might want to use that, it is a very, very, very useful technique. I think it is important to know what you're dealing with in terms of the technique for the wires, because they don't all work in the same way. So you have the sliding, the rotation, and the penetration. The harder ones use penetration, and therefore they can perforate more. I think it's important to know the accessories that are available to help you. And I think the main potential problem is obviously perforation and extravasation. So I think it's important to have the skills to know how to overcome that. And I think as we have new technology, we should embrace it, because it opens up new fields for our interventions. Thank you.
Thanks, Joey. I have a quick question, Joey. Well, first, great presentation. I think if there's a beak, there's a way to open it up. When do you choose between bare metal stents and cover stents to cover your tract you created with the CTO wire?
I think most of the time you can cope with a bare metal stent, because a lot of it is, there's a lot of hard tissue there from previous surgery. The reason why we used a covered stent for the IVC one, for instance, we knew that we were creating a track outside the circulation completely, and therefore we needed to have covered stents. So what we did there is on the CT scan, the distance ranged from 11 to 12 centimeters. Now, that may not sound like a big difference, but when you've got the renal veins and the hepatic veins just at the edge, you need to make sure that you're not going to cover them. So we ordered a funnel-type stent, 2 funnel-type stents with the funnel bit uncovered and the rest covered, telescoped them upside down, and then like that we had a range from 8 to 14 centimeters depending on how much we telescope. So you can actually do it at that time. But we don't always use covered stents is the answer. And certainly for ducts and for these, the chronic duct with the LPA, those were all bare metal stents. You don't need covered stents.